February Controversies in Cardiology. A very exciting, very, very relevant topic for everyone who takes care of patients. The topic being on the new guidelines for cholesterol management. How do you really implement them in the real world? Just to tell you a little preview of the next few meetings that we'll have, February 25th is Dr. David Moliterno, who's editor of JACC Intervention from University of Kentucky. And his topic is going to be on diabetes and coronary artery disease, March 25th. We're privileged to have Doug Packer from Mayo Clinic, who was the leader of the Cabana trial. And we're going to be talking about atrial fibrillation and the impact of the Cabana trial. In April, Peter Liu from Ottawa. In May, Mandeep Mehra from Brigham and Women's. And in June, Marianne Rabinovich from Stanford. I just wanted to introduce Dominic Grasso, who is taken over from Debbie Young. Debbie Young had put together the Controversies for many years and retired, and Dominic is taking over. It's actually a very difficult job trying to coordinate all of the elite visiting professors that they have, and their difficult and complex schedule with Dr. Fuster's difficult and complex schedule. And Dominic has the daunting task of trying to maintain Debbie's legacy. And the nice decorations in honor of Heart Month, February, are thanks to Dominic. So thank you very much. Without further ado, I'm going to introduce Ben Beer, who did a very, very good job on a relatively difficult topic. I will give a brief overview of the Controversies topic. Ben?
Thank you, everyone. Thank you, Dr. Gibson, for coming here. So my name is Ben Beer. I'm one of the first-year fellows here in cardiology. So over the last 4 decades, the American College of Cardiology and the American Heart Association have interpreted and summarized the scientific evidence into clinical practice guidelines with recommendations to improve cardiovascular health. The main purpose of the guidelines that will be addressed today is to address the practical management of patients with high blood cholesterol and related disorders. The review provided and the discussion today will try and translate the most recent clinical practice guidelines regarding cholesterol management for our patients and explore their application in the real world. Overall, the guidelines that we have in 2018 are more aggressive and intensive based on the recent RCTs that have been released since the last 2013 guidelines. I wanted to briefly summarize what I felt was the most important part after extensive review. First and foremost, I think for all individuals, a heart-healthy lifestyle should be emphasized for the reduction of atherosclerotic cardiovascular disease, or ASCVD risk reduction. And for patients less than 39 years old, lifestyle modification should be the mainstay of treatment, with medication interventions being reserved for the patients at the highest risk. And now we'll go to the other end of the spectrum. For the patients with secondary prevention of ASCVD, is the recommended use of high-dose intensity statins for a goal reduction of LDL-C of greater than 50%. And in our very high-risk patients, an LDL-C threshold of 70 milligrams per deciliter has been recommended. And then if you cannot achieve that recommendation, ezetimibe should be added. And then if still that level cannot be reached, that's when we reach for the PCSK9 inhibitors, with a discussion of these medications at the cost-benefit analysis for each individual patient. For patients in the 40 to 75-year-old range with diabetes mellitus and LDL-Cs over 70 milligrams per deciliter, it is the recommendation to start moderate dose statins regardless of the 10-year risk calculations. And then for patients with diabetes and high risk factors, high-intensity statins should be considered in this population. For all patients being evaluated for primary prevention of ASCVD without diabetes, between the ages of 45 and 75 years old, a clinician-patient risk assessment and discussion is recommended prior to starting any therapy. The more in-depth the conversation, the more trust and likelihood of successful intervention adherence can be achieved. Within this population, if patients have LDL-C greater than 70 milliliters per deciliter and a 10-year ASCVD risk of greater than 7.5%, starting with a moderate intensity statin is recommended. For these patients that achieve borderline risk of 5 to 7.5%, it is now recommended that further stratification should be done and more intensive discussion with their provider should be happening. This is where coronary artery calcium scores can be useful, where patients with high scores can actually tilt patients towards therapy. This calcium score can be used in populations where the statin therapy is uncertain. If the score is 0, treatment can generally be deferred or delayed unless they fall into one of the higher risk groups for primary prevention. For patients with moderate risks and calcium scores between 1 and 99, statin therapy is now preferred. And if the score is greater than 100, statin therapy is indicated unless deferred by the patient or there is a prohibitive risk. Finally, assessing and improving adherence to cholesterol medications is recommended as part of normal treatment for use of medication therapeutics. Techniques for addressing patient adherence should continue to be refined, including a multidisciplinary approach from the patient, provider, medical facility, medical insurance companies, and pharmaceutical companies. There's a lot of gaps in our knowledge based on the treatment of cholesterol in younger patient populations. And RCTs should continue to be designed and targeted at answering the questions remaining in this practice, particularly in our young patients. In addition, our elderly patient populations do not have much evidence to guide our therapy at this point. Further study is needed, and intensive clinician-patient discussions should be had for all patients in those two groups. Thank you.
Thank you, Benjamin, for a very good review of a very complex subject. What is exciting about the subject we're going to be discussing today is that 50 to 70% of what we will be discussing happened in the last 5 months. So this is one of the fields in medicine that has moved most rapidly in the recent few months. And I think this is actually by itself is very exciting. Well, we have with us Dr. Michael Gibson, and the curriculum vitae is about 5 pounds. But we will summarize it. A very accomplished person, of course. He was born in Oklahoma, and then he had his went to college at the University of Chicago, where he obtained his MD degree, and then he moved to Boston, where he had his internship and residency at the Brigham. Then he became a fellow in cardiology at Beth Israel, and then eventually chief medical resident also at the Brigham. Now, following his pedigree actually is amazing. He has been in a number of places, all very well known to all of us, but let me start. First of all, he, in 1993, he took a staff position at the Beth Israel Hospital, and then as associate professor very soon after at the Brigham, and then associate professor at the University of Pennsylvania, professor of medicine. Then he moved to California, San Francisco, where he was the chief of interventional cardiology and associate chief of cardiology. And then he went back to Boston at Beth Israel, where he's at the present time is professor of medicine, and is the CEO of the Bain Institute of Clinical Research and associate chief of cardiology. So, lots of things about Dr. Gibson, which I will summarize. First of all, in the editorial board of about 10 important journals, among them Circulation, the Journal of American College of Cardiology, also the Intervention, Journal of American College of Cardiology, etc. Now, in terms of awards, it's fascinating. He got the first award was in 1984, which is it's quite interesting, the first 2 awards, actually. 1984, National Young Investigator Award in Orthopedic Surgery. So what in the world were you doing there? Well, but I have more to say about that, because lots of things happened in 1984. So in 2003, he got the award of the Chinese People's Liberation Army General. So just to give you a little bit of a sense of the diversity here. But anyway, he had a significant number of awards from the John Paul II Hospital in Krakow, Poland, as a gold medal, at the University in Istanbul, in Turkey, and top doctor forever in all this year after year in the Boston and national area and so forth. Now, it is fascinating that the number of projects that he has participated is actually exactly 98. So 90 until very recently, and in the last 3-4 years, he has 8 extra projects. So very rarely you will see somebody with so many projects, but it's interesting because in all these places he has been, he was, in addition to what I said, was the director of the database for TIMI between 1997 and 2009. And then he was also a very important role at Duke in education, as a trialist, and as a consultant. So he really knows the world. Now, what about the literature? Well, he has about 600 papers with an X index of 112, which is pretty good. And he started with observational studies. Then one of his main contributions has been in really establishing method in coronary angiography, structure of the heart, etc. All these TIMI scores and all of that, really he's the one who developed this. So it's a major contribution of a very meticulous person, is to really set up methodology of how we read things. And then in most recent years, he has been involved in a number of pharmacological trials and studies, and certainly he's now a pioneer in a number of studies in antithrombotic therapy in coronary artery disease and otherwise. So here we have a very accomplished individual, has worked almost in every area of cardiology, and it's a pleasure to have you here today, Mike, and I'm going to give you, just for you to remember this visit, I think it's the second one in Mount Sinai. Let me give you this plaque that reads that you're an outstanding person. Great. Many words, but this is the summary. Thank you. Thank you. And then, yeah. Okay, good. Yeah, sure.
Just so it really happened. I'll be in the middle, okay? If there's no picture, it didn't happen.
Okay, thank you. And now what you will do, you will sit here, perhaps in the middle, and then I'm going to call the rest of the panel. Jason, you're here. I think I saw you. Then we have Jeff Mechanic, and Jose Miller, and Don Smith, and of course Benjamin. Well, this is not easy, I must tell you, with so many changes in this field and so many obsessive drives by certain people that we have to go into some detail, and I'm going to address 5 different aspects. One will be very brief, which was about the guidelines that came out actually in 2002. I was actually part of that. And then we will go into what happened in 2013. And then we will focus most important in the subject number 2, is that is the present guidelines, what is important. Then we'll go into great detail. Then we go into some technical aspects of number 3, and then about the future, number 4. In number 5, we are not going to talk only about LDL. We are going to talk about HDL, triglycerides, Lp(a), and other anti-inflammatory approaches to the problem of atherosclerotic disease. So a lot to do. And let me begin by, perhaps as an introduction, what happened in 2002? Well, in 2002, there was the panel from NHLBI in which cholesterol was viewed as a concentration of cholesterol in blood. Was very high or was very low. And then the question was acting on cholesterol levels. And you still remember it was very simple, but was the first time that cholesterol was taken seriously from the point of view of guidelines. This was 2002. Now, at that time, the issues of overall risk, the calculator, the age, what level to be reached didn't exist. So what happened in 2013? The advance in 2013 is that not only you act on cholesterol levels, but you act on the whole risk factor profile. And that was a significant advance. However, a calculator comes in where a lot of debate, not too good. And in the 2013, there was not such a thing as you should reach a specific level of LDL cholesterol. So with this, what happened in the present guidelines? Well, first of all, they look at the overall risk. The calculator is a little bit better. They're getting more into age, not too much. And then we have the issue that now we are going into a number of reaching levels of LDL cholesterol in some of the situations that we will be discussing. So I'd like to ask you, Mike, when you see these 2002, 2013, and now 2018, do you think we are moving forward?
I think so. I think it's amazing that it took till 2002 to have the body that you mentioned. I think people were very critical in 2013 of moving away from a goal. I think the epidemiologist had weighed in and said, well, there's really no randomized data that changing cholesterol to reach a goal is beneficial. I guess it's interesting having a son who's a quantitative genomicist. He and I argue and fight a lot, and he says, you're silly, all these trials you're doing. You just need to look at Mendelian randomization, Nature's randomized trial. And what you see for the PCSK9 variants and for the ezetimibe-like variants, the Niemann-Pick variants, and all these variants, what you see is that the greater the reduction over a lifetime gives you greater benefits. And there is a dose dependency in the genomic data as well. So really, we have the LDL hypothesis that lower is better. It seems to be well substantiated with statins, also substantiated with ezetimibe, not all that well substantiated with CETP inhibitors. But what seems very clear from genetics as well is that lower is better. The longer you achieve that goal, the better. So I tend to be of the mind that a little bit like the 2013 guidelines, that as long as someone can tolerate it, I personally think we should drive down LDLs as low as possible. But I may be an outlier in the panel, but that's my own personal view.
Understand it. Well, a couple of things that I think are important that we realize before we get into the details is that, first of all, the way that we express HDL, LDL in this country is not necessarily the way that is expressed in many other countries, and certainly many of the European countries. And it's just worth to mention that the milligrams DL in this country is you actually have to go to millismolar liter. In other countries, which is 40, you divide by 40. So always remember the number 40, and that is 40 milligrams DL is 1 millimolar per liter in other countries and so forth. This is very important. It's a lot of confusion, but never forget this number because it's something we have to stick into it. The other aspect that I think is important is that of course, if you are a very high risk and you decrease a high risk with a statin by 50%, whether you have another group of patients with very low risk and you decrease by statins 50%, is all linear, but the maximal impact is on the high risk because you really, the number of absolute number that you really have an impact is much larger, but relatively speaking is the same. This is very important when we discuss a number of specific issues later. Because interestingly, when you look at the CANTOS study, in which the LDL cholesterol is very low, you realize that the impact is very high, and is one of the situations that really this linear relationship, it just doesn't work because it's an anti-inflammatory drug, and it's a drug that works differently than cholesterol. Having said that, we are going to be presenting, I will be presenting 7 different scenarios that we have to make a decision of how to handle them. And this is all based on the guidelines and few other comments that I'm sure you people would like to discuss. And I would like to go from the easiest, or maybe from the less troublesome to the most troublesome situation. And let me start with number 1, which is a disappointment, is what happens with young people. That is, what do we do in children, let's say, between age 10 and age, let's say, age 18? And there's very little in the guidelines. What do we do in people over age of 75? Very little in the guidelines. And I think this is troublesome, except with the fact that when we get into familial hypercholesterolemia, there is some sensitivity in the guidelines to talk about between age 8 and age 20. And in terms of the elderly, there is also some sensitivity by the fact that if you reach age 75 and you are on statins, they don't say you stop them, you continue. And if you are in age 75 or over and your risk is very significant, they say, you know, it is reasonable to put the individual on statins. But certainly I think these guidelines really suffer because they are based only on data, and there is not much data on the younger population and on the elderly population. And this gets into the second question, Mike, to you, and that is, I think is a real, in a way, is a criticism, I would say, particularly in the elderly people, where in fact, some data that we are aware, it seems is working. What is your opinion?
Yeah, Ray Kosh and I had published some data on the elderly when I was at TIMI, showing actually in a limited group of patients, randomized data, that there were benefits in elderly. And I've always felt that there may be some benefits there. So I've never subscribed to the stop at 75 hypothesis. When it comes to the younger patients, again, you know, this is a lifetime disease we're talking about. We're talking about a lifetime of exposure to these LDL levels, and there is some compelling scientific reasons why you want to drive that lifetime exposure down. On the other hand, there are side effects, like the development of diabetes with statins. And this issue came up again recently with some of the new PCSK9 inhibitors that will be given once every 6 months as what people are calling a vaccination-like approach, where, you know, should people get vaccinated when they're younger with these drugs in their 20s and 30s to prevent disease in their 40s and 50s? Dr. Braunwald, for instance, argued that this might be a plausible idea, but I don't think that has been well vetted. There's certainly no data. My son, who's in his 30s, asks me this all the time, you know, should I start? So it's a very legitimate question.
Let me ask Dr. Mechanic, you're in the diabetic field, and I think it's interesting, when you look at the calculator on these particular guidelines, calculate over 10 years is a joke. Are you going to live 10 years, or we want to live a little longer? And you have learned a lot in the diabetic field of how diabetes, you have to detect it very much at the beginning, and then you go into the next 40, 50 years and you can do something about it. Why in the world we just still with a calculator that is so short term?
Well, I think the point is well taken that a lot of people don't use the calculator as the only way to assist their clinical decision making. Endocrinologists come at this from a different angle. We come at it from the diabetes angle, and most recently looking at comprehensive care. So we're dealing with a higher risk population. We're actually still waiting for the controversy to be settled, to what extent you really need to be aggressive with secondary prevention in patients with diabetes, and do these risk calculators, these pooled equations, actually help you, or does clinical judgment help you in the absence of a clear direction from evidence? So most endocrinologists might use it as a starting point, but we don't use it as the only piece of evidence. And a good example might be that if you have somebody with diabetes and you also have concurrent other risk factors, that we're going to just step up and be more aggressive regardless of the equation.
Makes things very, it's much more complex. Well, summarizing, this early age or later age is really ignored, and they say it's because there is not enough data. And what they say, the most important thing, aside of familial hypercholesterolemia or adults that have been taking statins for a long time, is lifestyle therapy. Now, to you again, Jeff, when we talk about lifestyle therapy, we develop a formula which is actually working, which is BWAT, which is basically what you can correct. The B is blood pressure, the E is exercise, the W is weight, the A is good alimentation, and the T is tobacco. Because all the rest, very little you can do. And what is your view? Because this is over the whole, all the guidelines is you change lifestyle and you discuss everything with the patient. This is in every paragraph. So basically, I'm just going through the first issue.
Right, so we're fortunate in 2019 that we actually now have some data. Before it was of theoretical benefit that structured lifestyle would be advantageous. I agree that you want to shotgun all the different component risk factors that are actionable. Obviously, some of them are maybe modifiable or non-modifiable, but the modifiable risk factors, they can all be approached with a structured lifestyle technique. Here are the challenges. The first challenge is implementation. We don't really have implementation at ready access. Not everybody has a gym right there in their office or access to the nutritionist. And second, for a long time, we didn't have data. Now we have data showing the positive effects of this approach that you're describing, Dr. Fuster, where you attack all of these different component and residual risk factors concurrently. You don't do them in a stepwise approach. You do them all at once.
Okay. Jose, this is let's go now into the second group of individuals. Basically, it's most of the population here, I guess, they didn't have heart attacks or any cardiovascular events. And you check your cholesterol or LDL, and the LDL is more than 70 or more than 100. And then the question is, what do you do? No atherosclerotic disease, no diabetes, and the cholesterol is not in the sky, but let's say it's 120, 130, the LDL, 140. And the question that is brought into this discussion in the guidelines is the first thing that you have to do is to get your calculator, Dr. Mechanic. So that's what they are asking. And then you get your calculator. And I just like to ask you, do you use the calculator?
No.
Okay. Let me tell you, we did recently, we did a survey on something else. Is how many fellows have read these whole guidelines? Can you raise your hands? Yeah, you had to. Which is bringing us into a reality of our lives, and that is we work a lot by intuitive feeling, you know. If there are 3 risk factors, you probably have your calculator in your head and so forth. But I think it's a very important issue that brings into discussion that we as doctors cannot rely 100% on guidelines because we don't read them to start with. And I think it's a lot of common sense. So, Jose, let's continue here. This is a debate that comes in the guidelines. There are 3 different types of individuals that I mentioned to you, 40 to 75 years of age, with a cholesterol LDL levels that are high, but not extremely high. And actually, this is the debate. The debate is, what do you consider a risk by which statins could be part of your treatment. And I don't want to go into the details, but in fact, it goes from 5 to 20% risk at 10 years. And the guidelines started with 7.5, and now there is data, very strong data, saying that even 5% in a period of 10 years, you should consider the statins in people with intermediate risk. What do you think?
So in primary prevention, if there are other risk factors there, the patient is hypertensive, obese, diabetic, with a family history of early coronary artery disease, I will be quite aggressive. If it's borderline, I'm not 100% sure. In primary prevention, I do calcium score much quicker if I'm not sure, more than what's recommended as a 2A in the intermediate group. I may do it in this group that you could call it intermediate, but it could be a little milder than intermediate. That could push me one way or another if the patient is, let's say, around age 50. If the patient is 70, I might, and no risk factors, no hypertension, nothing else, I may do nothing at that point. With an LDL of 130, I may be quite relaxed. It all depends. I mean, it's very difficult to give you an exact answer because it's tailored to each individual. It's not like I can give you, this is the real approach to all of them. Each person is quite different.
Jason, going back into this, I agree completely with Jose. Calcium score is coming very strongly in these people for primary, because it is 0, at least for 15 years, you can be relaxed. If it is more than 100, you might not be so relaxed. So I'd like to know your opinion, because I think it's coming into the primary prevention in the way that Jose described.
I agree with everything that's been said, and particularly Dr. Gibson's comments about lifetime exposure. And we know that there's this sort of ongoing linear relationship. The lower you get LDL and cholesterol, the better off you are. So my mentality is very much aligned with the thinking of other people here. We know that 1/3 of men are going to die from some sort of vascular atherosclerotic complications. So why be set when we know we can get it lower, we know we can continue to reduce their risk? Why stop when we've got an LDL of 70? And I do tailor the therapy, but I agree CAC scoring has a role, but my sense is if I can reduce someone's risk of dying in their lifetime lower, we should take that opportunity and not stop at an LDL of 70 or be beholden to the guidelines.
Don Smith, the question here is, when we use the risk factor profile as an statistical game, you may have 100 smokers and 50 develop disease and 50 do not. But if you're able to see the disease directly, and now let's make an assumption that calcification is looking at the disease, you don't think that this is the way that we should pursue with imaging, being able to see what is going on, more than the formulas that we are talking about, as stratifying people at the highest risk?
I think it's critically important. In the old days, essentially, nobody was doing calcium scores. I could send a person down the hall immediately and get an answer. Now you're having to wait 2 and 3 weeks because it is becoming the way to sort of look at that. MESA has a coronary calcium score calculator. And what you do is you put in the Framingham risk factors, but then you add the coronary calcium score, and it tells you you've either increased your risk based on that score or decreased it, because there's so many factors, known and unknown, that really affect that risk. So I use the MESA risk calculator using the coronary calcium score, and at that point I can really help a person understand what's going on. The other thing you do, you can use serial coronary calcium scores, and MESA has that by age group. What is the usual? Once you're up at 350 or 400, you're in sort of coronary equivalent risk. And so by getting somebody at age 40 and showing you have 100, you're not at any risk. But if you don't do anything in 20 years, by this serial population data, you're going to be at 400. They get the message immediately. You don't have to go around just sort of doing very much on that, and that's why I found the coronary calcium
Well, I
scores
think
so helpful.
there's a movement here, Javier Sanz. We are working, he and I actually, on a project. We have done 12,000 people with 3D ultrasound plus calcification, and I can tell you it just works. Is to see the arteries directly, it makes a tremendous difference. And this is a disease that actually starts in the iliofemoral region. So focusing the device in the iliofemoral, you can already begin to predict how the disease is going to subsequently to extend. So I think we are going to move much more into imaging of subclinical disease than we have done up until now. Well, having said that, we already discussed children and elderly, and now we discuss the largest population, which is primary prevention in people who have a high LDL cholesterol. Let's now go into number 3. Already we enter into people who have a stable coronary artery disease. And the question is, all what we have discussed, what is the difference when you get into this situation? And I can only tell you, just for discussion, and these patients not necessarily had previous cardiovascular events. These patients just have coronary artery disease, which is quite stable. And basically what the guidelines say is that once you have a high LDL cholesterol and somebody with a stable coronary artery disease, you should consider strongly to lower the LDL cholesterol levels to equal or more than 50%. And then within brackets, 2B, you reach a level of less than 100 milligrams DL. That's basically what they say for this type of patients. And I would like to ask Benjamin, what do you think about that? This is a patient with stable coronary disease.
Thank you, Dr. Fuser. So I think the biggest barrier to some of us is actually making sure patients are taking their medications when we know that they have the disease process. I think that allowing us to have a goal set of reducing by 50% allows us to keep patients accountable for what they're taking. So if we are seeing patients not responsive to their medications, it's either that they are resistant to it and require more intensive therapy, or that they're not actually taking the medications that we're prescribing to them. So giving us a set goal, I think, allows us as providers to keep our patients accountable and also keep ourselves accountable to making sure that we're engaging in that clinical relationship with our patients.
Well, the first goal is you give statins almost to everybody
Absolutely.
who has a stable coronary disease. That's the first goal. And then the question is, you have the 50%, that you try to achieve. I'd like to, before I go to Dr. Gibson, I'd like to go back to Dr. Mechanic, because the fourth entity is actually people without coronary artery disease who have diabetes. And the guidelines are exactly as described by Benjamin on patients who have coronary artery disease. That is, diabetes by itself is a stable coronary artery disease. Are you in agreement with that? In general terms.
I think I used to be in agreement with that because I was told I should be in agreement with it, but I'm not sure I'm in agreement with it now. I'm not sure that just because you have diabetes, it's equivalent to having coronary disease. In practice, however, patients with diabetes, particularly as Dr. Meller said, if there are other risk factors and looking at the totality of the risk profile, I have a very low threshold to put the patient on statins. I have some patients with early diabetes, and this is where definitions come into play, that really the demarcation between pre-diabetes and type 2 diabetes, or insulin resistance and pre-diabetes, these are very, very soft demarcations. So I think you need to transcend these hard rules that just because somebody has diabetes, they ought to buy that intervention.
They distinguish diabetes from pre-diabetes. I was very surprised, by the way, one thing, that in this country there are 40 million people with diabetes and there are 80 million with pre-diabetes. It's amazing how is it evolving, and this will end up with is the obesity, I suspect, which is driving this. But it's amazing. Now, let me ask you, Mike, now we describe the young and the older, and we describe the individual who walks in the street for primary prevention. We describe a stable angina or stable coronary disease. We describe diabetes. Now you have an individual who is really called high risk. And I think that's a critical issue because that's where all things are changing. What we are describing here is an individual, according to the definition of high risk, is an individual who has a history of myocardial infarction, of a stroke, or of peripheral vascular disease. But that's not sufficient. Such individuals should have had 2 measured events of the ones I am talking about, or 1 event and 2 risk factors. So I'm just saying, being precise to what the guidelines say. And then what happens is, here for the first time, you don't do any kind of formula or anything. You just try to reach an LDL level of less than 70 milligrams DL. So in a way, it's the first time that you see that you try to reach a level on the acute syndromes in the whole guidelines, and actually the first time that this happened. So, and I'd like to hear from you. What do you think we should reach, what LDL we should reach, try to reach in patients with high risk like that?
That's a great question. And, you know, I, again, subscribe to the you can't be too rich, too thin, or have too low of an LDL kind of philosophy. This person, we know they have the disease. We know they've had an event. Frankly, I don't care as much about risk factors, and I would be very aggressive. And by aggressive, I mean getting down somewhere at the obese hunter-gatherer level, you know, get them down to that range, 30 to 40 range if possible. With respect to risk, again, I think it's largely misunderstood. You see a lot of things published saying the risk is 10% versus 5%. Yeah, that's the difference for the population, but it doesn't say anything about our ability to take this patient right here and look at what's the positive predictive value that this guy sitting right in my office today is going to have an event. When you have events of this frequency, we can't do that. When you look at the positive predictive value, it's horribly low. You can say, well, what about using artificial intelligence and all that? Well, we've done that, and the results are very disappointing. They're not that much better than traditional logistic regression. There are some ways we're starting to quantitate risk through polygenic or polygenomic risk scores, which take into account genes. There is the genome, but then they don't take into account the exposome, what you're being exposed to. We have simple things like smoking, but what about more sophisticated things like small particulate matter, depending upon where you live? So I think our ability to predict risk is horrible. I think it's horrible because it's so complex. I think it's mediated by genomes, proteomes, microbiomes, but also all the things the patient's exposed to. And what they're exposed to is changing. And we just don't have great ways of predicting risk. And again, so I am more of the view that just drive things down as low as you can see.
Yeah, I think what you're saying is that, again, nobody will remember in 5 minutes what I said about you have to have 2 events plus 2 risk factors, 1 risk factor, who cares? It just doesn't work. And this is what perhaps are disappointing about the guidelines, but maybe we have to accept it, whatever it is. But I'd like to get into how you get into this level, how we make the LDL to go less than 70 milligrams DL. And now comes the question, what do you give to your patient on statins when in fact you cannot reach that level with the most intense statin treatment the patient actually is able to tolerate? And here comes the issue of ezetimibe and the issue of the PCSK9 inhibitors. And I'd like to start with a question which is interesting, and I think maybe you were involved with the study in TIMI. You know, there are 2 ways to address risk, or excuse me, to outcomes, I'm sorry. One is you pick up the first event, and then you compare the first event placebo versus the first event with that. But I still remember, because I was a reviewer of the ezetimibe first study,
It's a Murphy paper on multiple events.
And was extremely borderline, I have to tell you. And then they came right away with the second study, in which what they did is the number of events that take place into a period of time, then comparing that is much better. So this happened because we will talk about PCSK9 inhibitors in a moment because it's the same situation. So You have been working on this for a long time. How we should measure outcomes? You see, we should always go into the duration event, cumulative events, or we can talk about the first event.
Yeah, it's a great question. And, you know, so much of the literature focuses on that time to first event. Sometimes you'll look at the time to the most important event, like death, instead of MI. But what we traditionally do is look to the time to any event, because these people come back in with a lot of events. The time to any event or multiple event analysis looks at the burden of disease over time. Is that relevant? I think it is relevant because people with multiple events tend to have more fatalities. People with multiple events have greater resource consumption. People with multiple events, they're the people who failed your intervention. So I think there's some good intellectual reasons to do it. On the other hand, mathematically and statistically, it's a tough thing because there's clustering of these events, and you have to do a lot of mathematical gymnastics to adjust for that. In every single study I've looked at it, the multiple event analysis is always more statistically well-powered than the first event analysis. And for the life of me, I've never understood why sponsors didn't decide to use the multiple event analysis as the first.
I think this was a trick in ezetimibe, but has been a trick in the PCSK9 inhibitors. Let me go into some detail. You know, all the two main studies are evolocumab on the Fourier study, and then the alirocumab on the Odyssey group. And it's fascinating. There are two industries really competing with each other, and it's fascinating the way that the competition is going. So the Fourier thing was the first one that came out, and if you recall, these were patients, about 30,000 people with a stable coronary artery disease that were randomized into every 2 weeks subcutaneous injection of evolocumab, about 140 milligrams versus placebo. And then they were followed for over 2.5 years. And the question is, the results were actually significant, but were not outstandingly significant in terms of the relative difference. Then Odyssey came in with the same story, except the patients, I think, had a previous acute coronary syndrome within 12 months, 2.8 years, 20,000 people. And they also came, but a little bit less significant than the Fourier study. And it didn't take too long, actually 6 months, to Odyssey come back, about 2 weeks ago, into the summation of events. And now is much better. In other words, what we have now, you may say Odyssey is better than Fourier. And actually, the only thing they have done is the number of events have increased from 3,000 to 6,000 by just doing cumulative. And now the results are much more powerful. So,
but having been on the CEC for a lot of these trials and trying to write how you do this, it's very tricky. If someone comes in and they had chest pain, and then they had a diagnosis of an MI within 24 hours. Is that 2 episodes of unstable angina and an episode of MI? Well, many of these studies count those as 2 episodes. What I spend a lot of time on is saying, no, those weren't 2 episodes. That was 1 episode with 2 outcomes associated with 1 episode. So you really have to drill down into the details of exactly how these multiple event analyses are done. And it's much more problematic from that perspective.
Good. Now, let's move now, very similar to the acute coronary syndromes is familial hypercholesterolemia, which in fact, not necessarily the patients had an event, but they had an LDL cholesterol. You can define it, but more than 190 milligrams DL is actually the right definition. I think it's a fascinating story what has evolved over the last year or so in this particular condition. And I'm going to ask Jose, do you do genetic studies on people who have, let's say, familial hypercholesterolemia, or you assume the patient has familial hypercholesterolemia?
No.
Dr. Gibson.
Said no both times you asked him a question.
Michael, do you do genetic studies?
No.
Any of you do genetic studies? Okay, so guidelines came about 2 weeks ago about a group of experts who really said you must do them. And you know, it's an interesting situation because basically what you are talking about, there are reasons for, that's why we are bringing this into the discussion. There are 3 genes that are maybe affected, and you know, one is the low density receptor, lipoprotein receptor, the other is the ApoB, and the other is the PCSK9. And then a mutation on any of these 3 can really lead to the problem that we are discussing. Now, the question is the following, and there are some aspects that I think we should pay attention to. First of all, very rarely with the statins, you will be able to bring an LDL cholesterol less than 70 if it is familial. That's number one. The data in the literature is quite convincing of that. Second, you have your son, your daughter, age 12, with an LDL cholesterol of 120, and you don't have any idea if it is part of the familial hypercholesterolemia. So genetic studies really put the family into the right track. Could be heterozygous and very rarely is homozygous. It's a dreadful disease, I'm sure many of you have experience with, and it's terrible. So basically what the committee came out is called, is a scientific expert panel that came up with this discussion just a couple of weeks ago, that we should, from now on, should be doing it. I was not doing it until I called Emmy about a few weeks ago, and I said, can you do it? She says, absolutely. And so it's available, and it's available everywhere. Jason, what is your view?
I mean, I'm exactly aligned with you, Dr. Pfister. I actually went into Epic just last week and tried to order it, and it's not in Epic. It can't be ordered through Epic. I think it must be outsourced. But I think the time has come to start looking at more systematically at the genetics of this for family screening purposes, and I think also, you know, early some indication of whether you're likely to achieve some reasonable goal with statin and ezetimibe, or whether you should just expedite the treatment straight through to that plus PCSK9. But I think the time has come. I fully agree with you.
And actually, it's the most terrible type of hypercholesterolemia that you can have. Don, what is your opinion about what we are discussing here?
I don't use chromosomal. Yeah. I don't use chromosomal analysis. What I use, when I have to get the diagnosis of heterozygous familial hypercholesterolemia, is to give a PCSK9. I mean, you have to have that, or otherwise, if they don't have coronary disease, for primary prevention. So I do the one, Jeff, let me show you. I look for tendon xanthomas in the fingers. And people who have 190, you just do like this, and you'll feel that little teeny knot come up under in the tendon. And all you have to do is find one of those. That gives you 6 points. And then if your LDL is above 190, then you have 3 points. And familial heterozygous is 8 points. So you already have that. So that's the way with heterozygotes I've gotten, Robert and I have gotten these people basically without doing chromosomal analysis. But to have a chromosomal analysis make it much simpler.
Yeah, but you're getting, just a moment, you're getting into the adult population. You're not going to see a 12-year-old with all the things you describe in the skin. And here's the whole issue. And actually, they make a very important statement. This is a bad disease to have. And it's important to know if your children have inherited from the very beginning. Mm-hmm. And actually, it's interesting because in the guidelines, when I said there's only one condition that they are beginning to pay attention between age 8 and 18 is exactly that. Because they know that the treatment is beginning to evolve in these young people, preventing to have, you know, they have LDLs 120, 130, 140, but they begin to treat them. Yes, Jose.
Actually, in children with a bad family history where you suspect it, the pediatric indication is to give a medication for an LDL over 190 if you have also a genetic marker in that kid. Yeah. So after age 12, it was initially was approved actually Lipitor, let's say atorvastatin, and then rosuvastatin, but lately PCSK9 came strongly if the LDL is even more markedly elevated than that.
Yeah, you know, Jose, I understand what you say, but those of us, many of people here, I am following 3 families, and some are known by some people here. It's very troublesome, you know, because you have a son on one, a daughter on another, and another daughter who have actually LDL cholesterol of 150, and you say, well, I'm not going to start treating until age 30 when the LDL is 190. I think this is a mistake. I agree that we don't know what the statins do when you give them from a young age. That, I mean, we don't know. But to say we will not do it until he's 190 at young age, I think is really, in somebody, if you have the genetic studies and they tell you that there is trouble there, I think you have to be much more alert. Even preventing obesity, even with the health issues that we are talking about. Well, so in fact, the final number 7 I wanted to talk about is how you follow all these cholesterol and LDLs. And you know, Don, whenever we change treatment, we look about 2 to 3 months what the treatment has done in terms of the LDL. Basically, one has to be, you cannot do what we see so many times as physicians. The patient goes into statins, the LDL goes down, and the patient stops taking the statins because the cholesterol is already normal. When there is no, this will go up again. And I just like to emphasize that and what you have to say about it.
Generally, 50% of people, even with coronary disease, will stop their statin within the first year. And so I think the thing to do is to follow them more carefully within the first years or 2, you know, quarterly or even 3 times a year. And then you're just always measuring and showing them where their values are. The other thing is the Glagoff trial, as you know, took 1,000 people. And they did intravascular look at one of the 1.5-inch plaques. And then they got their LDLs with PCSK9s to all sorts of levels. And you can see exactly, they went back 18 months later, did the same study to see who had grown a plaque and who had shrunk plaques and who were stable. And so if you show that to people, you'll show that at 80 for LDL, half the people are continually slowly making plaques, half are regressing. If you go to 60, 100% are actually regressing their plaque. And when you show that where they are on there and where they want, I tell you, that gets them very excited about where they want to be and what they'll do. So the more I think we can visualize what plaques and coronary atherosclerosis are to people, they get involved in it very much. And I don't, you need gimmicks. You need to show what plaques are in rubber. You need to show the Glagoff trial, whether they're reducing or making plaques. So those are the things I think that may help this horrendous drop-off in taking statins within 6 months.
You know, in the Freedom trial, interestingly, ended up taking statins 40% of people. The remaining 60%, despite of coronary disease and so forth, they felt so well that they stopped. So we have a real issue here. It's just terrible. And it has to do even with people who know they have disease. Now, we have to talk about 4 entities, and I want to, maybe 15 minutes, HDL, triglycerides, LP(a), and the results of the CANTOS studies, anti-inflammatories. So I'd like to start with HDL. And maybe I will ask you, Mike, we all know that niacin fails, fibrates fail, we all know that. But it was quite striking when something else failed, and that is the cholesterol-esterol transferring protein, which in fact what it does, just for people to become aware, it gets HDL and puts the HDL into LDL, so it's bad news. That enzyme increases LDL and decreases HDL, so what better than to give an inhibitor? And 4 studies gave an inhibitor, and the HDL cholesterol raised into levels of 100, 120, and so forth. And the results were actually negative, except when they correlated with the decrease of LDL. And I'd like you to perhaps giving us your view of HDL. Certainly it doesn't play a role, the concentration. And I say these 4 studies in which the HDL were in the sky and nothing happened.
Yeah, I think the experience you referred to, it's been very disappointing. In the Accelerate trial, we lowered LDL 37% and had zero impact on events. So the LDL hypothesis was violated. The HDL hypothesis was violated. With this class of drugs, though, you know very well, we have a lot of off-target toxicity with modest blood pressure raising, modest CRP raising that may offset some of the benefits. I'm a little more enthusiastic about HDL, but I think we have to use a different word. I think the HDL that was made in those studies by the body may not have been functional HDL. Yes. And I think we're moving away from HDL as a number and moving away from the HDL hypothesis to what I would call the cholesterol efflux hypothesis. Mm-hmm. We now have 2 papers in the New England Journal showing in the outpatient setting, those people who have better efflux have better outcomes. Then we have a paper published in your journal in JACC by Gilles Montelasco saying in STEMI patients, those people who have worse efflux have worse outcomes. And what was fascinating in that study is that difference in outcomes emerged within the first 3 months of the STEMI. So something's going on with reverse cholesterol transport that's related to outcomes. I think when I look at it, you have to give the right drug to the right patient at the right time at the right dose. And I think all those studies may have missed, and we are doing, and this is a shameless plug for the 17,000 patient trial I'm leading of infusing ApoA1 after MI to see if we can improve outcomes.
So it's wonderful. It's wonderful. You just, I was going to talk about efflux, but you already talked about it. But I would like to ask Jason, this is an interesting, basically what is being used are human macrophages, in which you label the cholesterol there, and then it's in contact with plasma, and such macrophages deliver the cholesterol into the plasma. If you clean the plasma of everything except HDL, then you know the capacity of HDL to capture. And the data is fascinating, particularly the last data on STEMI, very significant results by measuring efflux. Jason?
Yeah, I think it's a fascinating biology, and it really comes down to we're moving away from LDL levels and concentration to HDL levels to HDL function. And I mean, we've done the cholesterol efflux studies in my lab as well in the yellow study. And I think it's a great biology, and looking at HDL function is key, but I'm sure you'd agree for clinical practice, it's an unwieldy assay, that it's important to have rigorous standardization. I don't think it's ever going to become a clinical tool we'll be using in the consult suite for patients.
Yeah, there's 4 different ones out there right now, but there's one group that claims they have a point of care device, and we'll have to see if it's good.
I just would add one last thing to the HDL levels for completeness, that in addition to this, the CETP inhibitors, there's also been Mendelian randomization studies which have also shown that HDL levels are unlikely to be causal in driving atherosclerosis. So I think we've really triangulated on the fact that it's not HDL levels, it's HDL function that's critical.
Let's go into triglycerides. Jose, why triglycerides were not part of the discussions many years? All obsessive approaches were on the LDL and HDL, but triglycerides were left a little bit out of our thoughts. And it's coming back. This is the only reason why I'm mentioning.
The original studies show that triglycerides had no impact on events in the future. Eventually, many studies show that they do have an impact and significant impact. And then the drugs to reduce triglycerides had no events on impact up to the reduce and the jellies in Japan, which may have nothing to do with the triglycerides, by the way. But we know that higher triglycerides have an impact on cardiovascular events, and there is at that point, epidemiologically, we know low HDLs have an impact on cardiovascular events, and high triglycerides tend to go with low HDLs in some populations. So nowadays, we're going to be more, I would call it more aggressive, and maybe treating these patients with a new only working fish oil and not the old fish oils, or not the fibrates that did not have any effect. I think any study for triglycerides that was done on top of a statin showed no effect at all. And people said the statin is the one they want to go. But now, with the new fish oil, we'll probably say this had an impact on top of a statin.
Jeff, there are a number of studies going back into triglycerides that now suggest that we need to have a stress test, and the stress test is actually non-fasting triglycerides, which is fascinating. There are a number of studies coming out saying that non-fasting triglycerides are telling you the real story, compared with fasting, which is artificial. What is you have a comment, Jeff, and maybe you don't?
When you're looking at triglycerides, I think you have to be fasting because they will go up, and then you don't know quite where you are. If you have a person who doesn't have high triglycerides, it doesn't matter whether they're fasting or not. I think that the thing with triglycerides is many of these studies are faulty. The triglycerides are only important to reduce if you have two things. Triglycerides have to be generally over 200, and HDL has to be less than 40. In all cases where you look at studies that have just looked at those groups, you find decreased risk reductions, whether you use a fibric acid or whether you use a niacin. So some of these trials, you have to look at non-HDLs to see whether the difference that you get between the drug, for example, niacin and the placebo, basically, are that different. And if they're not, at least 30 milligrams per deciliter difference in non-HDL, you're not going to get an effect. Yeah, but it doesn't mean that solo trials of niacin haven't shown reductions in heart attack and increased lifespan. So it's how big you make the difference.
Yeah, but just one question, Don. You made a comment which I think I want to. You say, well, if you are non-fasting, it will go up. Exactly. That's how we work with beta blockers. Beta blockers, you can say it works or doesn't work. If you look beta blockers at rest, you probably would not give to anybody. The question is how they work with exercise. The same happens with the stress testing and the heart rate. You look for ischemia. You don't look at ischemia at rest. Mm-hmm. And what is really evolving now in a number of studies is the level of the increase of triglycerides in non-fasting has prognostic implications. And I just want to emphasize that. These are not the studies that are published in the New England Journal of Medicine, but it's in good journals, and this is evolving from some places. Yes.
I just want to bring up another point that a lot of times, rather than being a target of treatment, it's a metric, and it reflects disease like insulin resistance. So we've recently had a few patients at Kravis Center who have come in, one triglyceride of 6,000, another a triglyceride of 1,800 non-fasting, and it set off all these alarms. Patients came in, and they actually had early type 2 diabetes, prediabetes, A1Cs were over 5.7. They had abnormal adiposity. We got all over them with a very aggressive lifestyle, weight loss, and actually their triglycerides come down to normal, and actually non-fasting triglycerides were nowhere near those ranges when they adopted good lifestyle habits. So it's a marker of metabolic disease, whether it's dysglycemia or adiposity-based chronic disease.
Well, I'd like to comment, Mike, the study on triglycerides that really made significant impact into the field. The reduced investigators study actually from Boston, where they gave this icosapent ethyl, which is a purified drug which lowers significantly triglycerides, and they were able to lower triglycerides significantly in people who had levels more than 135 milligrams DL. We are talking about 8,000 patients, just published in the New England Journal of Medicine 3 weeks ago. And 8,000 patients, primary endpoint, heart endpoints, and these heart endpoints actually decreased from 4%, were from 22% to 17%. These are heart endpoints by reducing the triglycerides. So maybe there is still some hope in terms of management of triglycerides other than obesity and everything we usually talk about it. Any comment?
Yeah, very provocative study. It is published in the New England Journal. That's very good. It still has to be reviewed by the FDA, which is quite a different level of rigor. We'll see how that goes. There were a lot of concerns raised in the placebo arm. There was a concern raised about the mineral oil that was used as placebo actually absorbing and preventing the absorption of the statin, driving up LDL levels. Whereas you quoted a 25% or 20-25% relative risk reduction, the level of LDL that went up in the placebo arm might account for 5% of that, but certainly not all of it. So even with those criticisms, it looks pretty robust. There were some increases in bleeding. You know, if I did a trial and there was that excess risk of bleeding, people would say, aha, gotcha, can't give that drug. There was a slight increase in AFib. But I think one of the overarching issues, what's the mechanism? And I don't think we have a good explanation. Alexander Leaf at the Mass General, during a time where you were there, had done studies on pigs and showing that these types of fish oils stabilize membranes and reduce ventricular arrhythmias or inducibility. And certainly in the study, there was a reduction in sudden death as well. So I think we have to start thinking outside the box. It's not always plaque rupture. These people also have arrhythmogenic deaths, and these drugs may have a lot of, I hate the word pleomorphic, but there may be non-traditional mechanisms of the benefit.
But still remember the the health, because many of these people are obese actually and so forth. Now I want to move into Lp(a). Lp(a) has been a huge molecule for discussion over the years because in Asia, for example, is a risk factor that has very predominance with high Lp(a). But the best study, or the largest study, was just published in The Lancet about a few weeks ago, and many of you probably are aware, and they did a meta-analysis, but well done. It's one of meta-analysis of individual patients, so it's not a meta-analysis just going to the paper. 30,000 people. And they had Lp(a) measurements. There are questions about the technology. They tried to standardize in the best way they could, so I'm not going into the details. But the results are striking in terms of Lp(a) really having an impact in cardiovascular events, particularly in those who also have high LDL, treated or not treated with statins. So it's very significant. There are other studies that have suggested this, but this is actually quite significant. So the question that we have is, and we see young people, and certainly they mentioned this here, a number of people who are very young, with some raise in LDL, and then they have high Lp(a) developing events at a young age. So, and the problem is, when the LDL was counteracted with the statins, Lp(a) didn't drop. So statins do nothing to Lp(a). And the question is whether the PCSK9 inhibitors are going to have an impact or not, because it seems they can drop Lp(a). Mike, do you have any comments? And maybe Don will ask you to.
Well, I hate to go back to it, and I hate to say my son is right, but he pointed out some very interesting things, again, with Mendelian randomization. When you look at Mendelian randomization studies and look at the impact of genetic variants that have a statin-like effect, and of course you have your PCSK9 variants, when you look at those two together, they predicted the results of Fourier. If you had a statin genetic defect or a statin genetic variant and a PCSK9 variant, when you added those two together, you got the predicted benefits in Fourier. What would be fascinating here would be to look at the PCSK9 variant along with an Lp(a) variant and see if those two add anything together. You know, with the CETP inhibitors, the Mendelian randomization data said when you add the statin effect with a CETP variant, there was no additive benefit. So the Mendelian randomization predicted the outcome of these studies. I think it'd be an interesting exercise to look at the independent contribution of lifetime exposures to those two variants to see if they do predict outcomes. I think that'd be interesting.
Yeah, I think what is worth it, and everybody mentioned it, a young person who no risk factors except LDL, perhaps to measure Lp(a). The question is, what do you do with it? That's what the problem is, and as we all know. Benjamin, let me finish by saying that not everything ends up with the LDL cholesterol level, and now we have the Cantus study, anti-inflammatory drugs, and I just like to make a couple of comments, and that is, this really is significant because the LDL cholesterol levels were normal there, about 70, and then you have a significant decrease in cardiovascular events. But some other drugs, methotrexate, fail, and so when we talk about inflammation, there are so many pathways. The Cantus, the monoclonal antibody counteracted, the interleukin B.
Interleukin 1
B, better. Yeah, so when the others, methotrexate, nobody knows how it works, and so colchicine. So at least we have a new thinking or concept that whenever we attack a biological process, there are so many pathways, and it depends if you're lucky to attack the right one. And so, Benjamin, what do you think about, were you excited about the Cantus data? It's very expensive, by the way, the drug, but that's a different issue.
So I think the excitement is limited by the fact of what the cost of these studies and what the cost of the new drugs that we're going to be able to treat based on the amount of impact we're going to have on the population. I think that looking at inflammation on a whole, knowing that it can increase the risk of cardiovascular disease is important. The problem comes is, are we going to be able to have a cost-effective way of controlling these for a large group of patients? Because we do have, statins are excellent because they're cheap and easy to prescribe across the field, but if we have a subgroup of patients in a small area and we're using a high, and we do find a marker, let's pretend, that we can decrease the risk, is it going to be cost-effective to apply that to that population specifically?
Mike, final question. PCSK9 inhibitors, very expensive, but now they really drop the cost and it's becoming affordable. So I think this was a push from the scientific world into the industry, and this is one of the successes. I think, what do you think about it?
Yeah, I think scientifically, that was a big advance. Scientifically, the PCSK9 inhibitors are a big advance. Sadly, the economic reality is setting in on some of these. But they have made adjustments from, 10 to 12,000 a year down to 6 to, ultimately, if they can get down to that $4,000 a year price range, that's competitive with Crestor in the old days at 3,200s. I think they might get there. We talk about the price of these drugs, but when we look back on the past 25 years and see a 30% reduction in all-cause mortality, it wasn't because we're doing better in terms of diabetes or smoking or obesity. I think a lot of what we have been doing played a role. You have to spend that $1 billion before you have drugs that cost pennies a day. And as a society, we have to decide, how are we going to incent drug developers to have a return on their investment, which we all benefit from when those drugs come off patent? Think if beta blockers were never developed. Think if aspirin or statins were never developed. We wouldn't have all the benefits we have today. So we've got to get the incentives right for everybody.
Okay, questions? Yes.
With reference to how to begin treatment in diabetes these days, we have a number of endocrinologists on the panel, and things have been turned upside down. What does one do? Do you go to big dose dosing or GLP-1 agents, or preferably you use insulin like you used to? Do you drop so many of the other agents, the thiazide, pyridones? What is the feeling of, particularly of the endocrinologists? What recommendation?
So if the question's algorithmically, how do you introduce the medicines? We just published our 2019 diabetes algorithm in endocrine practice. Metformin is still first-line therapy, but let me just preface my remarks that first-line therapy is actually patient activation. The second thing you do is structured lifestyle. Then, with the pharmacologic intervention, we have to get out of this mindset that we jump right to medicine first. But metformin is the first-line medicine. That will probably change at some point because there are no CVOTs with metformin. The problem is, and this gets back to the sort of ambient argument here, which is the cost of these other medicines. And the SGLT2s and the GLP-1s and the DPP-4s, they're all very expensive. We don't want patients to be taking secretagogues like sulfonylureas, and insulin is just in theory not the best medicine for somebody with type 2 diabetes. But the answer would be still metformin first, and then if weight is really the issue, GLP-1, if cardio and cardiac prevention and CVOT is the priority, then the SGLT2s. That would be the simple answer.
Thank you.
Other comment, question? Yes, Marianne.
So when the statins first came out, we knew they reduced stroke rates, and we thought that vascular dementia would decline. And unfortunately, we have some patients that stop their statins due to cognitive decline. Besides ApoE variances or any other genetic predisposition, you think, to the cognitive decline seen with statins?
Mike, can you answer?
Boy, you know, I think, well, certainly with the PCSK9 studies, there were very, very careful neurocognitive studies done showing no worsening of neurocognitive status with the PCSK9s. I'm not as familiar with the statin literature. I know a lot of people say it's the case, but I'm just not as comfortable that there's a there, but I think it needs to be studied more intensively from what I can see.
Yeah, I remember hearing that the PCSK9 inhibitors in development had some signals.
But
then they've been studied, but it's been short. It's only been like 5 years of that, right? Not longer term.
Sure,
but
fair enough.
I don't know if you've seen in your office, I have patients who swear that they have a fog with certain meds, and you stop it and it changes, and they go to different medications. Like Jose, what have you find?
I have some, go ahead.
I would say that I have a rare patient who complains that his memory has been affected by a statin. It's the exception. And I usually tell them to stop it and then see what happens. And they tell me it has improved, and I try again, and they tell me again it does it, and then we stop it. Interestingly enough, and this has not been published, I consider it stress test because those patients present with significant dementia within 2 years. So I think that we should use statins to prevent dementia, but I have a sense that there are some individual patients where it has an effect, but that's very rare.
Yeah, I think that I've seen 3 patients over 30 years, basically. One person was a pianist and just forgot her repertoire as soon as she started a statin. Another lady who was postmenopausal started taking one, and she couldn't figure out from her friends who was married to who. Okay, there was a professor here who just thought his cognitive thing just went down as soon as he stopped it. So what I've seen is acute changes in mental functioning, very, very rare. But all the studies show there's no decrease in mental functioning. Many meta-analyses show that, so I wouldn't worry about that. It's just these unusual cases.
The problem is I don't know how this is measured. This is why the trials on muscle problems is less than 3% have, when in real life, when you have studies done open, are 5 to 15%. So I think it's a tough question. I don't know how it has been addressed, though. Yeah.
Let me just add that metformin, there's actually data with metformin having salutary effects on cognitive dysfunction. There's a whole body of literature. So whenever you intercede with this network of metabolic events, you're going to see a whole portfolio of downstream events involving organ systems.
The 4S trial, actually, one of those huge trials, every 6 months gave mental functioning tests by phone to people on the statin and not on the statin. There was no difference in that over a long period of time. At least 4 to 5 years of every 6-month mental test function.
Well, if I ask you who is the President of the United States, some people here probably don't remember. In some, well, I don't want to go any further. Anyway, thank you very much. It was a very nice discussion.